Waheguru Ji Ka Khalsa, Waheguru Ji Ki Fateh. Today we've come to the City Hospital in Nottingham to interview the consultant heart surgeon, Dr. Jaswinder Singh Jutley, Rajwinder Singh Jutley, and to talk to them about the work that they're doing. I think you'll find that they're an interesting character. They've written a couple of books on this topic, which is linked with Formula One racing. And also I'll be talking to Josh Hill, who is Damien Hill's son, regarding racing and what the link between coming to see a heart operation being done. So let's first meet Dr. Rajwinder Singh. Khalsa, Waheguru Ji Ki Fateh. So Rajwinder, why don't we start by asking you some questions about your background, growing up, education, your family, and all that sort of stuff. So can you give us a quick summary on that?
Sure. Well, I was born and raised in Nairobi in Kenya, and I came here at the age of 19 to undertake undergraduate education, which I did in Scotland. Qualified as a doctor there, and spent most of my basic surgical training in north and northeast of Scotland and Glasgow before I came to England to do my higher specialist training in open heart surgery. I was appointed here just over 3 years ago as a consultant, and I live just outside Nottingham. I'm married to a wonderful wife, Anita, and I have 4 children in good old Punjabi traditional family making. And that's my basic background. Basically East African Indian, educated in Scotland, working in England, and with plans to return back to the country of my birth very soon.
Okay, so what I know that you've founded a charity in Africa called the Pan-Africa Heart Foundation. So what was the reason behind sort of opening a charity in Africa? Why don't you do, for example, one in the UK?
Well, the reason for opening an African charity was to try and put something back into the continent. The continent was responsible for my upbringing. It's that's where my family is, and that's where our businesses are, and that's where, we've created our family businesses and family wealth. So we've taken a lot out of Africa, but I think it was time to return something back. And what can you return other than money or financial things? What you can return is what you have in your head and what skills you have in your hands. And it so happens that there is a massive disease burden in Africa that affects the young population, something called rheumatic heart valve disease. And this happens as a child when you get a sore throat infection and you don't have access to penicillin. And you don't have penicillin, so a bit of the bacterial wall lands on the heart valve and subsequently destroys it over the next 15-20 years. And typically the person in the 20s and 30s are short of breath. And in Africa, from the time that they're diagnosed to the time that they die is usually a matter of months. And what they do need is a straightforward valve replacement. Now, that's an exceptionally expensive operation. Here it costs about £15,000. But through Pan-Africa Heart Foundation, we've tried to make it readily available. And we can do that operation now safely with good results for less than £5,000. So the idea was to restore a long life back to the people in the prime of their lives, because they normally have dependents. They have children who will then end up becoming orphans and street children if they're not treated. And the beauty of what we offer is that if you do the valve replacement, they then go back into work, they start contributing to the economy, looking after their children, and they're productive people. And interestingly enough, north of Pretoria and south of Sudan, for a catchment area of 400 million people, there's only a handful of surgeons, and we're talking less than 10, who can actually do that operation and do it well. So it was time to not only return back home, but to also offer them that operation safely and also train the local surgeons to get them up to scratch. The other thing that's hitting sub-Saharan Africa at the moment is coronary artery disease, and that affects people in their 60s and 70s, typically those with high blood pressure, high cholesterol, diabetes. So as Africa starts to get more and more affluent, as it happened in India, that population starts to get coronary artery disease. Now these are people with money. And the idea of Pan-Africa Heart Foundation was to, again, operate on these people who have the money to pay and then charge a premium which allows me to then fund the people who can't pay. So very much a Nottingham Robin Hood model. That was the idea of doing it. We can't really do that in UK because rheumatic heart valve disease has been eradicated as people start to have introduced more sort of better healthcare systems, and poverty and overcrowding becomes a thing of the past.
I mean, one of the questions I had was regarding heart surgery. Now, you're an open heart surgeon, which is not like the normal heart. I mean, they're all doctors and consultants, I assume. But what is it different? Why? Well, I thought nowadays we're going more for keyhole surgery. So why are you opening hearts up all the time now? And I assume there's not many with your background or skill in doing heart surgery.
No, you're absolutely right, actually. A lot of people get confused between a heart doctor and a heart surgeon. Well, the two are very, very different. We have what we call medical doctors that treat the heart. Those are called cardiologists, and typically their title will be doctor. Whereas a heart surgeon, who are far, far, far fewer in number. For example, in the East Midlands, there are only 4 surgeons that cater for the entire catchment area for East Midlands. Only 4 of us. And we have, for that number, roughly approaching 50 cardiologists. Right? So a lot of cardiologists sometimes call themselves heart surgeons because it's easier to describe what they do. But we operate on the heart. So typically I will open the heart through the chest. I will put pipes in the heart. I'll stop the heart. Whereas what cardiologists tend to do is treat the heart using medication or stents, which they tend to approach through the groin. So what you're going to see today is open heart surgery, which is offered only at about 24 centres in England. And there's less than 200 open heart surgeons in Britain. And in terms of Sikhs, there's only 4. Sardar Chara. And, well, I happen to be one of them.
Rajwinder, you're also an examiner with the Royal College of Surgeons in England. What does that actually entail? I mean, do you mark papers, I assume, or do you write them? Or what's your enrollment with that?
Well, you can write papers and mark them if you want, but actually it's a little bit more glamorous than that. I'm an examiner for the Royal College of Surgeons of England, and not only do you examine junior surgeons to a set standard in England, you also have examination duties in Egypt, in Sri Lanka, in India, in Trinidad. So you do have to give your commitment to travel and examine people in those countries to the standards, to the British standards. And a lot of that is OSCEs, interviews, scenarios, case studies, case-based discussions. And I think it's a privilege to be asked to be one of the examiners, because it makes you believe that obviously you deliver a clinical standard that's not only good enough for your patients in the UK, but you're now translating that standard to different parts of the world. And the ultimate plan is to be able to introduce that in sub-Saharan Africa as well, and train the surgeons in that area to the standards of the UK, which are recognized generally to be the best in the world. Again, this was a step that I took to be able to introduce that back in Africa through Pan-Africa Heart Foundation. And as it so happens, this Saturday I fly to Addis Ababa in Ethiopia again to examine surgeons of the College of Surgeons of East, Central and Southern Africa, and to introduce British examination standards and training curriculum into that part of the world.
Oh, no, that's really good. Now, I do want to also mention, talk about some books that the Dr. G has written. And one of his books is this one. It's called The Fitness Manual for Motorsport. There's obviously a link between driving and how your heart is working. So let's talk about any book. I mean, what was the reason for you to link it, the heart surgery going on with, motorsport?
Well, you're bringing in a completely different facet of my life, which is a facet that I thoroughly enjoy, actually, which is motorsport. And again, it comes back from my East African background. I grew up seeing, prominent rally drivers such as Joginder Singh, Shekhar Mehta, Bjorn Voltegaard, Juha Kankanen, Hema Mikla. All of these drive the East African Safari, which was part of the World Rally Championship. And back in the 1990s, 98, 99, 2001, I had the privilege of actually driving in those 3 events. And I didn't do very well at all, but I enjoyed them thoroughly. But that gave me a very unique standing. I happened to then therefore see the world of motorsport and also see the world of medicine. But nobody had really made the links between two. And I then was asked by Haynes Publishing to provide very objective scientific advice as a doctor to amateur motorsport drivers on how to prepare themselves for motorsport. In other words, different things, like how do you do hydration on the day, what do you have for breakfast, what do you eat during the day when you're racing, how do you actually cope with an emergency if you're trapped in a car, somebody's cutting you out, how do you react, and what are the questions that have been asked, how do you not panic? So in 2003 I wrote the first edition. And within a few years, all copies were sold out, and some very prominent rally drivers were on board because it was a very large safety component. Colin McRae, Louisa Aiken Walker, the RAF, all of these were on board. And so in 2009, I published the second edition, which I wrote with a very well-known sports scientist in the motorsport world called Andy Blow. And it's gone from strength to strength. In fact, now it's the core book for the MSA driver development program. It's selling around the world, and every 5 years I have to produce the subsequent edition depending on what's new and what isn't. And people like Mark Webber, Red Bull F1 are now sort of involved in contributing in what they do too. Again, all about safety, all about giving the amateur drivers who don't have physiotherapists, sports scientists, doctors, how they can prepare themselves better for the day and improve their times.
Okay, one of the things that you've also been involved in is the invention of a drinks strategy. I need to ask you about that because what is the drinks strategy? Is that linked with, how can you improve someone's performance purely because of what they're drinking?
Well, I think if you want to ask that question, you want to ask Josh Hill, because it turned out last night when we were having dinner that he is actually on the drinks himself. And I think you're on the yellow tube, there. Right. And well, actually, this is a spin-off that I'm involved in, and there's a bit of a story involved in this. Basically, it's based on a human fact that came to light a few years ago, that actually not everyone sweats equally. So humans have an 8-fold variation in the amount of salt that they lose in sweat, but nobody had actually invented a quick, rapid, reproducible and accurate test to predict how much salt they were losing in sweat, therefore what drink they needed to replace those losses. So a couple of years ago I stumbled on some medical technology in America. I signed a non-disclosure agreement with them, tested 200 people, and then gave those 200 people a special drink that I then made from off-the-shelf formulation to increase their performance. And the results were too good to ignore. We stopped cramping. We had drivers racing out in Africa who, would change a complete suspension and were never tired, were never fatigued. And since then, we've ended up developing a company called Precision Hydration, which I'm now part of as one of the founders, and we now have testing centres in Canada, New Zealand, Australia, South Africa. The England rugby team drinks the drinks. We have Premiership football teams that drink these drinks. The EIS used it for the Olympic squads. We have a couple of F1 drivers who are on this, and it turns out last night that Josh Hill too is on it. So maybe he's the man who'll tell you whether it's made a difference to him or not.
No, I'll talk to Josh when we're going down to the theatre about this. But so I think it's fascinating, that the link between sweat and the strategy that you put forward. What was the role in the medical consultancy that you've done for Porsche? Because I've seen your your picture actually in one of the sort of pamphlets. What was your role with the Porsche team then?
Well, the link with the Porsche team came after I wrote the book, and Porsche were trying to invest in something called the Human Performance Center, because they realized that the most important component in the driver machine was not the machine, because they produced that really well, but actually the machine is of no use if the driver isn't fit enough. So they invested in a large facility on the British Formula One Silverstone Grand Prix track on the Hanger Straight, and built an experience centre in which there's a human performance lab. And Andy Blow was charged with writing programs on how to increase driver performance in motorsport, but they needed medical components. So because I'd written the book on it, I was asked to be the medical consultant there, which is where I've met a lot of the motorsport drivers and where I tend to spend a day a week as well.
With that, we're going to go down to the surgery with the doctor, and let's go and see what we can learn from there.
I start to visualize, like racing drivers do, they visualize. So when you see a racing driver on the track, he's thinking about how I'm going to do the first corner, second corner, racing lines, and suddenly everything that he hears, everything background noise fades away. That's my time. For 5 minutes I have to wash my hands, and in that 5 minutes I'm beginning to focus in on the operation itself. Well, what steps I'm going to take, how I'm going to follow that flow, the diagram, what extra instruments I may need, what am I going to do that's going to be unusual. Because this isn't a case I've been looking forward to. But he's only 63, you know. He's got his life ahead of him, so we've got to try and do the best.
Right. So while the doctor is just going to scrub up now and get ready to perform the operation. So how long do you think it will take for you to do this then today?
Probably, well, it's already started, so we're about an hour into it, and we're just about to go to the stage where I'm going to start putting the pipes in the heart. So from now on, I'm hoping to have finished by about 2 o'clock, and then get the patient out and stabilized. I'm not doing anything else today because he may need a lot of babysitting afterwards.
What's this patient having done to them, by the way?
This is a patient who needs two things doing. He needs bypass grafting, so we need to bypass the blockages in his artery, but more importantly he also needs a valve right in the middle of his heart repairing. Now the valve's leaking because the heart is enlarged and it has a series of heart attacks, and the heart itself is not working very well at all. It's not pumping very well, so he's a sort of medium to high risk case that needs his heart offloading with the help of a balloon pump machine.
So this is the patient's mitral valve.
Right.
This is the aortic valve. And what we're looking at here is a colour flow of blood across the mitral valve. So normally blood will flow from this atrium to this ventricle, and it'll be shown by a blue flow going down the screen. So when the valve is closed, there should be no colour going the other way.
Right.
So what you can see here is when the mitral valve closes, you see red going towards and up the screen towards the probe, and this is the leakiness of the valve. So you can see this jet going through the mitral valve, and this is what we'll attempt to repair today to stop this leak.
And you can notice actually the atmosphere in theatre automatically adjusts itself to the severity of the case. Now they know this is a high risk case, so everyone's a little bit more quieter, a little bit more somber. Everyone's trying to focus in, Josh. Everyone's trying to focus in on the job at hand. There's no talking. Everyone knows what they're supposed to be doing, and everyone's doing their job best. Yeah. So.
Okay, we're going to talk to Louise about this particular equipment here and what it exactly does. So Louise, what is it that your role is in this operation?
I'm a perfusionist, so we run the Heartland Machine, which is what this piece of equipment is. So when they're doing the surgery, they need a still heart and a bloodless field. So the blood is bypassed to this machine. So the pump of the machine effectively acts as the heart, and another part of the machine acts as the lungs. So we can drain back deoxygenated blood and give back oxygenated blood to the patient. So that's like the basics of our job, but we're also monitoring like blood gases and a lot of other parameters throughout bypass as well.
This must be a very expensive piece of equipment. Is this brand new? Or?
Yeah, this is a brand new machine. The actual pump base is about £100,000 per pump, and then all the tubing you see on the pump is disposable, so we use it for one patient only, so it's quite expensive when you think.
And how long will you be here? Will you be here, I mean, once the heart's taken out, does this machine then sort of come into action?
It's as soon as, well, the surgeon's actually cannulating now. As soon as he's cannulated, we can connect the machine up to the patient, and it's just when they're ready to go on bypass, and then it obviously depends on the type of procedure, but I'll probably be on bypass for a good couple of hours, and then we stay up afterwards for safety and make sure everything's okay after.
So the patient is virtually dead then for a short time while his heart stops and this machine takes over?
Yeah, when we give a high potassium solution which arrests the heart. So yeah, you see the ECG completely flat. There's no the roller pump is non-pulsatile, so the blood pressure line will be flat, so it doesn't look very physiological on the machine and the monitors.
देखो इत्थे एक गल कही है ना कि बंदा मर जांदा ਉਹਦਾ ਹਾਰਟ ਐਨ ਬੰਦ ਹੋ ਜਾਣਾ ਤੇ ਉਸ ਟਾਈਮ ਦੇ ਵਿੱਚ ਮਸ਼ੀਨ ਕੋਈ 1 ਮਿੰਟ ਲਈ ਉਹਦਾ ਹਾਰਟ ਬਿਲਕੁਲ ਖਤਮ ਹੋ ਜਾਣਾ ਤਾਂ ਮਸ਼ੀਨ ਨੇ ਸ਼ੁਰੂ ਹੋਣਾ ਆਪਣਾ ਕੰਮ ਕਰਨ ਨੂੰ ਆ ਜਿਹੜੀ ਮਸ਼ੀਨ ਆ ਜੋ 1 ਲੱਖ ਪਾਉਂਡ ਤੋਂ ਉੱਪਰ ਆ ਇਹ ਮਸ਼ੀਨ ਹਾਰਟ ਤੇ ਲੰਗਸ ਦੀ ਮਸ਼ੀਨ ਆ ਇੱਕ ਵਾਰੀ ਬਰਥ ਹੋ ਕੇ ਦੁਬਾਰਾ ਨਹੀਂ ਬਰਥ ਹੋਣੀ ਹੈ
Douglas Robbie, NG29240, 20th March 1949. Yeah, happy. He's having mitral valve repair, COBG ×3 and LV lead placement. He's a sort of medium to high risk case as well, poor ventricle due to previous MIs. He's also got severe intracardiac dysynchrony, hence why he needs an LV pacing lead for CRT therapy later. And he needs a mitral reduction annuloplasty to reduce the MR, which he has, which is at least moderate. The plan would be to open, to heparinize, to put in IBC SVC cannulation. Again, Louise, I'll let Arvin tell you whether he wants a Pacifico for the SVC or whether he'll go through the right atrium, and he'll have a look when he opens up to decide. We'll go on bypass, put the retrograde cannula in, cool to 32 degrees, cross clamp, give aortic root cardiplegia, and maintain it retrogradely every 20 minutes. We then do the SVG to the first obtuse marginal and SVG to the RCPDA, Lima to LED, close the Lima to LED graft off with a clip, please, Laura. And then, probably before the Lima to LED graft, put the screw-in lead, so it's done and we don't have to lift the heart up again. Yeah. So the screw-in lead will go high up on the lateral wall near the LA appendage. Yeah. Arvin's going to get the lead. Then open the LA, do the mitral repair, de-air, leave a flop.
So what is it you're exactly writing here then now?
What I'm going to do is basically what I'm doing now is actually breaking each step down of the operation. So what I tend to do is I tend to have a very basic setup for my operating, right? So I then modify each of the operations depending on the severity and how I'm going to run it. Yeah. And this is a concept that I'm trying to bring into the motorsport world as well. Similar to what I'm going to run the case, Josh will be running, he's raced that weekend. So he'll need to know, for example, instead of the height, weight, index, the risks, whether he's going to run blood crystalloid, induction, pressures, everything. He's going to know what tyres to run, what he's going to have his aerodynamic setting at, what the ambient temperature of the track is, what the track temperature is, what the humidity is, where he is lying in position in the championship, how much fuel he's going to keep on board. Now this is public knowledge. Everyone in this theatre needs to know what I'm going to do today, at what stage of the operation I'm at. Obviously what he has got to be something that's secret, and maybe only 2 or 3 people need to know what his tyre settings are, his PSI is, and fuel and ballast weight and so on and so forth. So I'm just going to write it down.
Okay, so one thing that I found really not disturbing, but the smell is very strong here. You must get used to that after a while.
Absolutely. I mean, it's one of the first things that we're introduced to as a junior surgeon is the smell, and it just becomes part and parcel of it. And
I think it's great. I mean, I wish I was a surgeon, but I'm just not that bright. But I'll be honest with you, I think it's amazing that...
You don't have to be bright. Sometimes you have to be stupid to be a surgeon and choose another career.
No, but ਇੱਥੇ ਆਉਣਾ ਬੜੀ ਔਖੀ ਗੱਲ ਆ. I mean, ਦਿਲ ਦੇਖਣਾ ਕਿਸੇ ਦਾ ਕੱਢਣਾ, I think it's very difficult. I think what you do is...
ਹੁਣ ਦੇਖਾਂਗੇ, ਮਿਲਦਾ ਉਹਨਾਂ ਨੇ ਖੋਲ ਲਿਆ ਹੈ ਤੇ ਛਾਤੀ ਖੋਲ ਲਈ ਹੈ ਤੇ ਤੁਸੀਂ ਹੁਣ ਦੇਖਾਂਗੇ what the heart looks like, what the ਦਿਲ ਕਿੱਦਾਂ ਲੱਗਦਾ ਹੈ.
Yes.
And we'll show you in a few seconds from the top.
Okay, so now we've come out of the theatre to talk to Josh Hill. Those that don't know him, his father is Damon Hill, the famous F1 championship driver, as well as his grandfather, who happens to be Graham Hill, who was also, I think, twice world champion, if I'm not mistaken, and Josh can correct me in a minute. So let's have a quick chat with Josh about what he's seen and what does it mean for him. So Josh, coming here to the theatre to see an open heart surgery, what was the purpose behind all this?
Well, my manager knows Raj from stuff he's done in the past, and Raj mentioned that he was doing this program to try and get racing drivers in to watch him and how his team works together, because it's very similar to how a race team works with a race driver. So there's a lot of synergy there, and there's a lot that both worlds can learn from, really. And it's been a pretty interesting day already. It's only just started, but it's going to get a lot more interesting, I think.
Okay, so you haven't found it. How have you coped with it? Because I know that we had to get a chair for you, but you're not about to faint, are you?
No, I think I'm over that now. I'm sort of I'm getting used to it, and it was a little bit difficult at first because, to be honest, I haven't really seen anyone in those sort of states really, especially. And Raj took me through to intensive care, and that's when it sort of really hit me. But it just becomes that bit much more real when you see it in real life, obviously, and it really hits you. So I'm all right now. I'm coping.
No, because I think that when you come in for the first time, the sort of drilling and the smell and the noise and the whole atmosphere is very, very sort of somber in many ways. Because, but no, I think you've coped with it okay. But so what do you hope to take away from here then?
Well, yeah. Firstly, on the noise and sort of the smelling, it's apart from the somberness, it's very similar to a garage. So it's a race garage. So I was sort of getting used to that by then. I didn't even notice the saw starting up. So, from today, I'm just hoping to try and learn a few things. Raj just showed me his whiteboard concepts, and it's definitely something that can be implemented in motorsport, really, and in the way you work with your race engineer and your mechanic, and just make sure you've got everything for like the important people to see, so everyone knows what's going on at the same time. They don't have to keep asking around and bugging you when you're trying to get your head into the zone for a race.
Okay, now the other question I had was when I was interviewing Rajwinder, one of the questions came up about his drink strategy. Now, are you on that drink strategy, and what do you think about it?
Yeah, my trainer actually gave me the H2 Pro salt tablets, and because I needed those for my training. We're training in hot weather, and I was getting cramps in my legs and my feet, and it was hampering me training basically. And I took those, and without even knowing Raj was involved at all, I didn't even know Raj at the time, and took those and stopped like that. It wasn't even a gradual process. As soon as I started taking them, that was it, done. All you do is just drop it in your bottle of water, and away you go, done. It's quite incredible.
Yeah, I think we'll have to tell more people about this drink strategy that the doctor has made. I think the rugby team in England is using it. Formula One races are using it, and so on. So let me ask you the last question about your career in terms of Formula One racing. I assume one day you're hoping to go into F1. What's your plans for that sort of thing?
Yeah, obviously the ultimate goal and ambition is to get into F1, and we're pushing as hard as we can to make it there. So far I'm about halfway up the ladder, if not just over halfway. We're looking at doing British F3 next year, which would be pretty good. And I think we're doing quite well because I'm winning races, so it can't be a bad thing.
So what is there like a set procedure? You have to win X amount of races before you can get into F1, or can anybody just if you're rich enough, get in, buy a car and start driving it?
This is the thing with motorsport. There's no sort of set procedure, and there's no real ladder. When you're in motorsport, you know about the motorsport ladder. You know where all the championships are ranked compared to each other, but there's no official ranking table. There's no sort of like third division, second division, Premier League. It's not like that. It's and definitely not like what Raj does with 20 years of training before you're allowed to become a cardiac surgeon. So it's no sort of fixed thing, but there is a general sort of gentleman's agreement that you do have to go through quite a few of the ranks and perform well, and the people who perform well tend to get the best seats in F1 when they get there. It takes a bit longer, but they'll get a better seat when they're there.
Okay. Well, I want to thank Josh for coming out of the theatre and out of his time to talk to us today. So we're going to go back and just see the last part of the operation. So I'll morke chaliye theatre bich dekhnu uthe hon doctor ji karde. Okay, so they've opened the heart now, and what they'll do, the next step will be to take it out. So the machines behind me will be keeping the man alive. The Dr. Jutley will be performing the operation, but the first consultant has basically cut the man's heart, his chest open, and so that they can access the heart. So that's what you're seeing behind me at the moment. They'll also take a vein from his leg, which they will use to operate on.